My name is Doris Hansen from Moffitt Cancer Center. Today I'll be presenting comparison of time to next treatment or death between Frontline, daratumumab, lenalidomide, dexamethasone, and bortezomib, lenalidomide, dexamethasone in transplant-ineligible patients with newly diagnosed multiple myeloma. Clinical guidelines include the use of induction chemotherapy followed by an autologous stem cell transplant in patients with newly diagnosed multiple myeloma. However, in patients who are older and more frail, transplantations may not be an option. In the National Comprehensive Care Network guidelines, there are two options that are listed as preferred regimens that include daratumumab, lenalidomide dexamethasone or DRD and bortezomib lenalidomide dexamethasone or VRD. There have been no randomized controlled clinical trial comparing these two regimens head to head. However, other studies or indirect comparisons have been performed. The objective of our study was to compare the time to next treatment or death between frontline DRD compared to VRD. In addition, we wanted to look at or add to the existing evidence regarding comparative effectiveness between DRD and VRD in transplant-ineligible patients with newly diagnosed multiple myeloma. Time to next treatment was selected because of lack of this data or data on progression in these retrospective databases. And it is a valid measure because it is able to capture the relative effect between treatment regimens, but is not a direct proxy for progression-free survival. The data source that was used for this study was the Centris database, a de-identified electronic medical record or academic database used in 22 institutions across 14 states in the United States. And it does have extensive medication or extensive information on medication orders, fills, administration. Here is the study design. Essentially, we used the Centris database to select patients who received frontline DRD or VRD between January 1st, 2018 to May 31st, 2023, and the index date was the date of initiation of frontline therapy. The method or analysis that was used for this study was the inverse probability of treatment weighting, essentially to adjust differences in baseline characteristics where each patient was assigned a weight based on the inverse of receiving DRD. We use weighted Kaplan-Meier curves to assess time to next treatment or death, and a doubly robust Cox model for patients who remain with minor imbalances. So there was 952 patients that met the inclusion criteria, but there was only 643 eligible patients for the study. We identified 149 patients receiving DRD and 494 patients receiving VRD. After inverse probability of treatment weighted, we had 302 weighted patients in the DRD cohort and 341 weighted patients in the VRD cohort. Here in this table, we demonstrate the patient characteristics between the two cohorts and identify that they were directionally similar between DRD and VRD. Mean age was 75 years. The majority of, or about 50% or slightly less than 50% of patients were female. And the Quant-Charlson Comorbidity Index, which is a 10-year mortality index accounting for comorbidities, was similar between the two groups at 3.8 versus 3.6 in the DRD versus the VRD cohort. There were some minor imbalances to include age as well as other race and index year. However, these were again adjusted for in the doubly robust Cox model. We identified that the median follow-up for DRD was approximately 20 months. For the VRD cohort was 21.5 months. In this slide, we show the results of the study. So essentially 32 patients or 32% of patients receiving DRD and 51% receiving VRD progressed to a subsequent therapy or died. It's important to note that patients who received DRD were 42% less likely to progress to a subsequent therapy or die, as evidenced by an adjusted hazard ratio of 0.58. The median time to next treatment for the DRD cohort was approximately 38 months compared to approximately 19 months for the VRD cohort. And as we see here in the Kaplan-Meier curve, essentially we see a proportion of patients who are less likely to progress or move to a subsequent therapy or advance a subsequent therapy, and DRD is in black, VRD is in red, and we see that patients receiving DRD were less likely to progress to a subsequent therapy or die compared to VRD during the follow-up time for the study. So certainly the study does have limitation like any other retrospective analysis does. So the data was obtained from a provider-based data source. So if a patient went outside of network, we would have missed some of that information. There was also administrative or right censoring, essentially noting that if a patient received a stem cell transplant beyond the data cutoff, we may have missed that information. We also were missing information on ECOG, variables required to calculate a frailty score, and cytogenetic risk, would not necessarily have changed the results, but would have helped us contextualize the findings of the study. And as I previously noted, time to next treatment or death is not a direct proxy for progression-free survival because commonly it underestimates progression-free survival because sometimes treatment may be discontinued for reasons other than progression by IMWG criteria. So in conclusion, our study did demonstrate that DRD was associated with a longer time to next treatment or death compared to VRD, as evidenced by a 42% risk reduction. And our study also supports findings from other studies in noting that DRD was found to be more effective than VRD in transplant-ineligible patients with newly diagnosed multiple myeloma, as also noted in the Doris or Pegasus or other adjusted indirect comparisons. And last but not least, in the absence of randomized controlled clinical trials comparing these two regimens head to head, our study does support the clinical effectiveness of DRD and hopefully will assist clinicians in informed decision making when treating patients in this setting. Thank you very much.